We are recording. So thank you all for joining us today and welcome to the final event in the Reproductive Freedom Summer series organized by the National Mobilization for Reproductive Justice. We've had some great talks so far and I'm looking forward to this third one in the series. If you're joining late and you haven't been able to access those, you will be able to find them on our website. Today, we will hear from 4 panel speakers, voices from Embattled States, including we have Triana Arnold-James, Katie Knutter, Toga Pendrake, and Kirsten Moore, each of whom I will introduce further when they go to speak. I am Susan Massey, and I will be moderating today. I am an organizer with the National Mobilization for Reproductive Justice here in Phoenix, Arizona. I am also a member of Radical Women, which is a socialist feminist organization, and a member of my union, United Campus Workers Arizona. Being from a state where abortion access has been particularly contentious, and we've been able to secure some wins in the fight back, I'm really looking forward to hearing about how the fight is going in other states and how we can support their efforts and share ideas. The national mobilization kicked off in summer of 2021 when the Supreme Court announced that it would hear the Dobbs case. The mobilization, as I'll call it for short, was initiated by Radical Women who reached out to activists and groups around the country with common cause to build a grassroots coalition to fight for reproductive justice. The way things were before the Dobbs decision came down in 2020, which overturned Roe v. Wade, was insufficient for many people who struggled to get access to abortion care due to factors such as cost and lack of availability of care or services in rural areas. So reproductive justice is not only about the right to abortion, but so much more. The mobilization, therefore, developed a set of 12 intersectional demands for reproductive justice, including access to free contraception and safe legal abortion on demand, gender-affirming care, an end to forced sterilization, and overturning state barriers to reproductive choices. You can read the full list on our website, as well as access informational resources and find details about how you can get involved and organize with us. Please see the agenda. They'll be posted in the chat. We'll have speakers go first, and then I ask that everyone save their questions and comments for the discussion at the end. And that portion will not be recorded. We do want to hear your thoughts, so please jot down those thoughts and questions in your notes so that you can share them then. So now for our feature presentation. I will introduce our first speaker. Let's see, I gotta look at my discussion here, my notes here. I think, Jordana, it looks like Triana has not yet been able to join, is that right? So I'm gonna move on to Katie Knutter and then we can come back to Triana when she is able to join. I gotta find my notes. Let's see. So Katie Knutter is the executive director of Wellspring Health Access. She has worked in abortion care in Kansas, Oklahoma, Michigan, and Wellspring's flagship clinic in Casper, Wyoming. We will be hearing from her about the fight for abortion access there and the work of Wellspring Health Access. Welcome, Katie.
Hi, thank you so much for having me. Can everyone hear me okay? Okay. I didn't hear it. Anybody here can hear me?
Yes.
Okay, great. Okay, sorry, I just wanted to make sure. I do apologize. I'm doing this from home, so my cats will join, and hopefully the headphones will help make them less loud for you all. Yeah, thank you for inviting me. As Susan said, my name is Katie Knutter. I'm the executive director of Wellspring Health Access. And we are an organization that works to open clinics that offer abortion services and other reproductive healthcare services, including gender-affirming care, contraceptive services, and gynecological services in what we call abortion deserts. So these are areas that have historically not had sufficient access to abortion services and do not currently have access to abortion services. As Susan mentioned, I have been working in these kind of spaces pretty much my entire career. I previously worked at an organization called Trust Women, which is an ongoing organization that has a clinic in Wichita, Kansas. We had previously opened a clinic in Oklahoma City, Oklahoma, that has been forced to close due to the fall of Roe v. Wade and the Dobbs decision. So I had a lot of experience early in my career working in those very, very hostile states. And then I was really pleased to be able to join Wellspring Health Access in continuing that mission. So Julie Burkhart is our founder. She founded Wellspring Health Access in 2021 with that goal of, bringing abortion care to those underserved places that either had not had clinics in a very long time or had never really had clinics and accessible abortion care. Um, she was invited by a group of people in Wyoming to open a clinic there. Our organization, if you look at our website, we have a headquarters address listed in Washington, D.C., but that's just a mailbox. We're physically located in northern Colorado. So, we're in the region, but in a state that is a little bit less politically hostile legally than Wyoming. But so I'm based about 3.5 hours from our Casper location, which is where our clinic in Wyoming is located. Most people are not really very familiar with Wyoming geography, but Wyoming is a very large state and it has one of the lowest populations in the country. So the population density is very, very low. I think Alaska is the only state with less population density because it's quite a bit larger. But Wyoming has a very small population. So that means that patients, unless they live in Casper, are typically having to travel many hours to see care. We see especially a lot of patients. Sorry, my cats are very involved. So we see a lot of patients from states where abortion is entirely banned, such as South Dakota, Idaho, North Dakota, and states where abortion access is limited, like Nebraska, Montana, and Utah. So, like I said, Julie Burkhart founded Wellspring Health Access in 2021 and was invited to open a clinic in Casper, Wyoming, which is kind of centrally located in the state. Cheyenne is the capital and has a slightly larger population, but it is located very close to the Colorado border. So those patients really can travel about 45 minutes to clinics in northern Colorado. It's our patients that are, about 3 hours from anywhere else or 4 hours from Denver that we were really concerned about. So that clinic they'd found a property. They had almost gotten the building ready to open in May of 2022 with the goal of opening before the Dobbs decision came out. It was in that gray area where we all knew it was coming, but it hadn't actually been announced, it hadn't actually been declared yet. And an arsonist actually broke into the clinic and set it on fire. So the entire inside of the clinic was gutted and had to be basically rebuilt. And while that was happening, obviously the Dobbs decision came out, and Wyoming, like many states, had a trigger ban, so had a law that had been pre-passed many years before to say that when Roe v. Wade fell and was no longer the law of the land, abortion would be immediately banned, which happened in many, many states across the country. And so our organization with another provider who offered medication abortion in Wyoming and some advocacy organizations and our local abortion fund, we all got together and filed a lawsuit with the state of Wyoming. Wyoming is a really interesting state. It has that real cowboy attitude of, let me just do my own thing. Don't interfere in my life and I won't bother with yours. And it comes out in very interesting ways in the current political climate. But a few years ago, the state legislature and then the people had ratified an amendment to the Constitution in Wyoming that says that the government does not have the ability to interfere in people's ability to make decisions about their health care. They had passed this aimed at blocking the Affordable Care Act from being implemented in their state. But we said, well, that sure sounds like the state shouldn't be able to make laws that infringe on a person's right to have an abortion then. That sounds like that to us. The state has not agreed, but so we filed that lawsuit then in 2021. It is still ongoing. We received a temporary injunction in that lawsuit that allowed all of the abortion laws in the state, of which there are many, to be blocked while the case is ongoing. We received a decision that affirmed that first injunction through the district court in the fall of 2023. And then, I'm sorry, the fall of 2024. And then this spring in April, we had oral arguments before the state Supreme Court in Wyoming. The Wyoming court system does not have an appellate court; it's district court, and then and then the Supreme Court. So that's where we're at. They've heard our case, but there's no legal requirement of when they have to make a decision. So we're hoping they take a long time to think about that because currently it means all of our laws are blocked. So we're able to provide abortion care to patients. And like I think I mentioned, or I don't know if I have mentioned this, we're the only clinic in Wyoming that offers both medication and procedural abortion. Um, like I said, the state had previously had a provider that was in Jackson, Wyoming, which is in the far western part of the state, in the northwest part, that offered medication abortion. But if you needed a procedural abortion, you would have to go out of state. And I'm sure as you all are aware, there are many patients who are not a candidate for medication abortion, either because it doesn't work with their life, their circumstances, or they're simply too far along to be seen for a medication abortion, or it's just not their preference. And so nationally, especially since the fall of Roe and since telemedicine restrictions on medication abortion have been loosened in many states, about 60% of abortions happening currently in the United States are happening through medication abortion, which is typically offered up to 11 weeks. Some places can offer it up to 12 weeks. We currently offer up to 11 weeks of pregnancy. And then about 40% are procedural abortions, which include patients who are in their second trimester. Our numbers are actually the opposite, though. In 2024, we had about 51% have patients choose a procedural abortion or have a procedural abortion. And so far in 2025, it's actually been a little bit higher of, I think we have about 58% of patients either choosing or needing to have a procedural abortion versus a medication abortion. Because what we find in states with low access, like Wyoming and our surrounding states, is that a lot of patients may have wanted to have an abortion earlier in the pregnancy, but they have been unable to access abortion care until they are in their second trimester or even a little bit later in their second trimester. And this definitely especially happens for patients who have other factors that are limiting their access to abortion services, such as patients who are very young, patients who are very poor and have, uh, inability to access transportation very easily, patients in rural areas, and patients with populations that just have low access to healthcare in general, such as undocumented populations. So basically, anything that would make it more difficult for you to access healthcare in general will make it more difficult for you to access abortion services. And we definitely see that in our patients. We work with a number of abortion funds to offer funding to all of our abortion patients. We have a no turn away policy. So if somebody needs abortion care, we will offer it to them if we can, safely and legally, regardless of the ability to pay. But that means that vast majority of our patients need funding assistance of some sort, whether directly to pay for their procedure or to pay for travel or both. So that's something that we have some really generous, amazing funders that have helped us be able to offer that. But it is a significant issue for our patients, especially our patients that live in rural areas. We see quite a few patients that are Native American from um, the western parts of South Dakota and North Dakota, as well as Wyoming. And those patients often need really a lot of funding assistance for travel because there's just not a lot of travel options. We also have helped patients access abortion care from 19 different states, which is mind blowing because Wyoming is not an easy place to get to unless you are kind of already there. But we've seen patients from the Southeast, Texas, Louisiana, just kind of all over the country who have come to us. Lots of times not because we're necessarily the closest clinic to them, but because a lot of the clinics that are closer to them have a long waiting time because they are seeing so many patients. So basically, what you have is that you have clinics just sort of inundated with patients if they're in states where the laws are not explicitly banning abortion. Um, versus, so I think we don't currently offer services in Colorado, but we are working toward opening a second clinic on the western slope of Colorado. So Colorado is a state with generally very good access to abortion care, unless you are on the western side of the Rocky Mountains. So all of the clinics that offer procedural abortion care and are mostly clustered in sort of the area near Denver on the eastern side of the mountains. We call it the Front Range, and especially in sort of the northern Front Range. So if you live on the western side of the Rocky Mountains, there's nowhere in the state that you can go that will offer procedural abortion care. There's very few clinics that will offer medication abortion care, but like I said, that's not always a great option for people, or they may not qualify, and it may not be the services they need. So that's what we're currently working to do, besides obviously operating our clinic in Wyoming, which, we had to pause for 7 months, or I'm sorry, 7 weeks in March and April in offering abortion services because the state of Wyoming passed three new restrictions this year. One that was a trap law, which is a targeted regulation against abortion providers that basically says that if you're going to offer procedural abortion, you need to meet all of the legal and like physical requirements of an ambulatory surgery center. So basically, you have to have a mini hospital, which we couldn't meet that restriction. And it's been found to be entirely, unnecessary. And then we also had a specific restriction that was going to require a waiting period for medication abortion tied to an ultrasound, which would have blocked our ability to offer telemedicine for medication abortion, as well as just making it much more difficult for patients to access that service at all. So we went to court again, and we finally got an injunction, but it took 7 weeks to get that injunction, which is not typical and certainly does not fit with the idea of, being able to seek redress in an appropriate amount of time. So we felt it was very discriminatory that they took so long to even, put it before a judge, despite our lawyers filing immediately. So that's kind of, what we're looking at currently. So we're just going to be waiting on those decisions with the courts, and we hope they take lots of time and fully consider it. We are feeling very hopeful that they will rule in our favor because it is pretty clear cut in the law. At least we believe so, and the district court judge believes so. That being said, we do foresee that if when we do receive that favorable ruling, that they will seek to amend the state constitution to remove those protections. So we would be facing, an amendment at the ballot. So we're, looking at how can people start to mobilize in the state. And to be honest, we seek a lot of funding from people, mostly individuals, but also foundations outside of the state to support these efforts. Abortion care is very subsidized across the board, and every clinic in America does not break even just on what patients are able to pay for services. That doesn't happen because
Yeah, for
it's
sure.
artificially low. So, we
Yeah,
really rely on support from individuals and foundations across the country to support our work. And so, that's something that we really appreciate. And um, just being able to tell these stories of our patients that even though they live in a place that's really remote and difficult and that is mostly forgotten, that their lives are important and their ability to access reproductive health care is also important. I think I probably
absolutely.
have
Yeah.
gone over my time.
Yeah, yeah. It's hard though. I
Sorry.
was gonna say it's all really interesting and it's all super important. So I know we'll have lots of folks who will want to talk about it more during discussion, and we'll
Yeah,
look forward to
absolutely.
that. But yeah, thank you so much for telling us about all that. I learned a lot.
Awesome.
All right. Next up, we have Triana Arnold-James. Triana is the president of Georgia Now, the National Organization for Women, as well as the founder of the Susan Jolly Awareness Program, which focuses on raising awareness about cervical cancer. She's also a mother of 12 and a U.S. Army veteran. Ms. Arnold-James is a longtime advocate for women's rights with a focus on addressing disparities that impact women of color. Just a few of her many accomplishments include authoring a House resolution to establish Ahmaud Arbery Day in Georgia, hosting a parallel event at the United Nations Commission on the Status of Women in 2024 centered on women's rights and health equity, and co-authoring a resolution for Medicaid expansion in Georgia. Most recently, she organized protests against the forced pregnancy of Adriana Smith, and she will be telling us today about the fight for reproductive justice in the state of Georgia. Please welcome Triana Arnold-James.
Hi, good afternoon. Can everybody hear me okay? I'm in my car.
Yes, we can hear you.
Okay, great. Thank you. I actually am in the middle of traffic headed to an emergency. You've done the introduction, and I just wanted to say thank you all so much for joining. And as you can see, I was prepared to do the presentation from Georgia, but I have this emergency that I have to get to, and I don't want to do a disservice to the presentation, even though I'm kind of stuck in traffic and I brought my notes and everything, but I would just be rushing through it, and my mindset is not there. For those of you, if you're a parent, if something happens to one of your kids, then you're not thinking about anything else except trying to get to that child. And that's where my mindset is. But I did email my notes to my presentation to Helen, and I believe she's gonna kind of go through it to tell you all about what's happening in Georgia. And I believe one of the things that I did not put on there was that we are currently working on Adriana's law. With all of the things that Helen is going to talk about in my notes in my presentation, since this abortion ban we've had in Georgia, we've actually had 3 deaths, and it's mainly, and it's been all women of color. And so that has to change. And hopefully, with our advocacy and our work, we can implement Adriana's law with our new governor that's going to change things, turn things around. We may not be able to do anything about the abortion ban right now. However, we can do some other things like Adriana's law that will help save lives. So anyway, I do have to go, and I'm so sorry that I'm not able to participate in the whole thing. But Helen, I believe, is going to go through my presentation, and if you all have any questions, she can give you all my email address, or if you want to just reach out to me via email, and I'll do my best to respond. Okay, thank you all so much.
Thank you and take care. I hope the emergency resolves well.
Thank you.
Yeah, thanks, Triana. We really wish you all the best. And Thank you for being so well organized. As you can tell, a mother of 12 is somebody who is very well organized and prepared because emergencies happen. So she did send me her notes, and I will do my best to give you the overview that she had outlined here. And she calls the fight for the embattled state of reproductive care in Georgia is a fight for health, rights, and equity. Georgia's at a crossroads. On one side is the promise of medical advancement, reproductive rights, and bodily autonomy. But on the other is a growing tide of restrictions, political battles, and limited healthcare access that disproportionately harms women, low-income families, and marginalized communities. This matters, and I'll tell you why. There have been recent changes in laws and policies. There is a huge human cost, as Triana told us. Women are dying from preventable conditions, and the widening healthcare gap on race and income. In the legal landscape, the thing to remember is that Georgia has a 6-week abortion ban. It's incredibly short. They have a so-called heartbeat bill. We know actually that at that point in time, there is no heart, so there can't be a heartbeat. I'm improvising here, filling in, but my God. There is a heartbeat bill that bans most abortions after about 6 weeks, which is often before many women know they are pregnant. There are some very narrow exceptions. Rape and incest, if there is a police report, a fatal fetal anomaly, or risk to the mother's life. These are currently under a legal challenge. The law is under a challenge, but it is still mostly in effect. And as Triana referred to the Adriana Smith case, if you're not familiar with that, as far as risk to the mother's life, that was the nightmarish case of a young Black mother who was in a car accident. She was, I believe, 7 weeks pregnant. She was basically killed in the car accident. She had no brain activity, but they kept her body alive until the fetus could be delivered. And it's just horrifying. That was without any consultation with her family or husband or considering her wishes. So the impact of this law has been, with all such ambiguity and really tight restrictions, has been confusion for both patients and healthcare providers. And there is a great fear of the legal consequences affecting even emergency care for miscarriages or ectopic pregnancies. And we've heard that in other states as well. In addition, I mean, just as far as basic health care, we know that Black women, especially in, all over the US, but especially in the most poverty-stricken states, have a high level of maternal death and infant death, is separate from the abortion issue. And Triana says more than half of Georgia's county have no OB/GYN. So your ability to be guided through a healthy pregnancy is very limited. Georgia ranks worst in the nation for maternal mortality, with Black women dying at 3 times the rate of white women. This is also compounded by the state has refused to provide for Medicaid expansion. That was a offer during the Obama healthcare process, where the federal government offered to pay to fund expanded Medicaid for a while, and Georgia refused to do that. And so they have not expanded Medicaid under Affordable Care Act, which would have made more people given them access to the care. So thousands of low-income women lack affordable coverage for reproductive health, as well as prenatal care and postpartum care. Who is most affected are Black women, who are already facing the higher rates of mortality due to systemic racism and healthcare inequities, and rural communities where limited hospital access means long travel times for care. And if you're in an emergency of a miscarriage or dangerous pregnancy, this is a life or death problem. And then, of course, it's a low income problem. Low income families have limited insurance, they have barriers to transportation, and a question of affordable child care to take care of families while their parents take care of urgent health care. So beyond abortion, reproductive health is comprehensive care. Reproductive care does include cancer screenings, sexually transmitted disease prevention, contraception, prenatal, postnatal care, and sexual health education. For example, cervical cancer is highly preventable. Georgia has higher incidence rates than the national average. And I remember those debates here in Washington State, or our liberal state here, where if the conservatives were afraid if you gave young women the very safe and accessible virus to prevent the cervical cancer viruses, they were, oh my God, they'll go out and have sex. So the right wing has just denied this access to really preventable care. The restrictions and funding cuts to clinics have reduced access to preventive screening like Pap tests and HPV vaccinations. That's the one that the young women need access to. So, a call to action. What's being done? Community organizations are providing mobile clinics and telehealth services. Advocacy groups are challenging restrictive laws in court. Faith-based initiatives are bridging trust gaps in underserved communities. And what we can do is push for Medicaid expansion to cover more women, demand transparent, science-based reproductive policies, support community health clinics, and encourage the human papillovirus vaccination and cervical cancer screening programs. In closing, Triana remembered the statement from Dr. Martin Luther King Jr., who said, "Of all the forms of inequality, injustice in health is the most shocking and inhuman." Georgia's fight for reproductive care is not just about policy, it is about life and death. And we cannot afford to stand still. The future of reproductive health in Georgia depends on what we do today. Well, thank you to Triana for all she does and for providing this overview of what's happening there.
Yeah. And this took the words out of my mouth. And also thank you, Helen, for presenting that for us so that we could get that information. All right, next we have Toga Pendrake. Toga is an electrician and activist in IBEW Local 520 based in Austin, Texas. He is an advocate for tradespeople of color and a member of the steering committee of the National Mobilization. He's been especially active in grassroots efforts to organize union leadership to take action for reproductive rights, and will be telling us about the state of things in Texas. Welcome, Toga.
Howdy. I guess it's hard to even know where to start with Texas. Basically, for anyone that's not very aware, Texas has the major cities are all considered blue, Democratic, liberal, whatever, and the rest of the state is considered red, Republican, conservative. Texas had attempts at banning abortion even before Roe v. Wade had fallen. They were trying to implement different types of restriction bans, passing laws that ended up being trigger laws. as soon as Roe v. Wade fell. Texas is still one of the states with some of the harshest and most restrictive laws. Um, Specifically, they do not have exceptions for rape, for incest. They have a muddy exception for access to abortion when the mother's life is at risk. And specifically, there were 20 women, 20 people who had lost pregnancies um, that filed a case. It ended up being called Zorowski versus Texas. Um, and they were basically challenging that the Attorney General would not clarify when an exception was safe. Doctors were afraid to perform the procedures even after ectopic pregnancies, after um, no responsiveness from the um, the deceased fetus. There was specifically the named plaintiff Zarowski has likely lost the ability to have children after after her child had passed away inside her, and doctors were hesitant to attempt a removal, and because of the length of time and the, in essence, putrefaction, um, has likely caused her the ability to have children in the future. Some of the other mothers in the cases were forced to carry the unviable pregnancy. The child was born and passed away minutes after being born without the direct support of the mother. And because of the way that the Texas laws are set up, the family was still forced to have a full funeral service for the child that had been minutes old, and again was known to be non-viable months ahead of time. Um, that's like I said, that's all kind of wrapped up in the one specific case, where again Texas was unclear on what constituted an emergency exception. The case was technically victorious in that a Texas judge found it unconstitutional, but minutes after the court case was decided, the Texas Attorney General instituted an injunction on the ruling. So he basically struck it down immediately after without, again, intending to make any clarifications, refusing to say when it was and was not safe. During the case, one mother who had a condition similar to Zorowski was reaching out to the Attorney General, the same one, to see if her condition qualified as an exemption. And again, they failed to clarify, they failed to give the information, they failed to give an exemption. The closest thing to a silver lining is this past legislative cycle, Texas has finally decided to pass what was called the Life of the Mother Act. And that law is meant to make a clear-cut exception, which again, apparently, even if you have severe medical risk, it's not necessarily enough to guarantee you the ability to terminate an unviable pregnancy. What I can say is that Texas is a state with no shortage of fronts to be fighting on. And it's been splitting the efforts of a lot of people. The most recent thing being the gerrymandering, the redistricting in Texas, which has been all over the news. And, a bunch of people are finding different ways of trying to combat it with uh, one with I guess this is kind of a proud point is that IBEW was helping get some of the Texas Democrats out of the state. And, that's something that we're thankful for, at least up until the special session ends. Um, when I talk about when I talk to other IBWs and other locals and other unions about the way things are here in Texas, they want to make suggestions along the lines of like, oh, you guys can try to get something in your bylaws, something in your contract that would try to help ensure, paid leave, the ability to travel, the just some sort of benefits that might help. And Texas has, I have a note here, Texas has tried to pass laws where they would charge you for a different felony for every county that you crossed while trying to seek an abortion. So if you passed 4 counties, it would be 4 charges alongside leaving the state to get an abortion. And that, while that ended up not passing, it still speaks to the level of vitriol that they have, where there's no other state, there's no other laws, even murder, where you could be charged per county for trying to travel to commit a murder. Texas had kicked the idea around of charging people with or seeking the death penalty on people who didn't even necessarily leave the state to get an abortion, where even if you had a miscarriage and you couldn't, or it was under suspicious circumstances, or basically they think that it was self-induced, still trying to seek the death penalty, where they're so pro-life, they'll kill you for it. The other thing that I wanted to talk about was that Texas has too many what are called crisis pregnancy centers that mislead and misuse information. They try to draw in desperate mothers under the assumption that they might offer abortion services or even support for pregnancies. And most of the time, they just bring the people in, they give them some kind of a sermon, they burn up state and federal tax dollars, and they mostly just run out the clock to where you wouldn't be able to get an abortion in most states. And then once you've passed the clock, once the pregnancy is at a point where you can't get an abortion in most states, they just cut off communication, cut off services, and have you deal with it as you will. Let's see. Like I say, it's just generally a rough time, and even amongst union members where I have conversations, like I say, we've had talks about trying to enshrine additional protections in our CBA, in our contract, and I have to tell my IBW members, my brothers and sisters and others in the locals, that we have to fight, one, for paid days off, and we have members in my company that are against us getting paid days off. Basically saying, the young man from Indiana saying that he doesn't think that the contractor should be burdened with paying us if we're not directly working. So that's the kind of uphill battle that we have when we're trying to include anything outside of a raise, outside of retirement funds, outside of contributions to the electrical training program. Just trying to talk to and convince men in construction that they need to care is always a struggle. And even if they do see it as an issue, even if they do see it as unfair or unconstitutional, they still don't necessarily want to roll up their sleeves and do the work to try to correct it, to try to address it. Let's see. We have well short of, I think, 3% of women representing us as IBAW 520, and that number has been increasing as time goes on. Our training director has said that he would hope to get the school, the training center, to a 10% women's acceptance rating. But when we have so many older people, so many good old boy right-wing Trumpers, they make it obviously a hostile work environment, and a lot of women don't see the benefit of staying in the program when they have to be berated or harassed by just construction workers that are meant to be leading, meant to be training. I can say that as a member of IBEW, as a member of our Central Labor Council, we have been working with groups like Equality Texas that specifically looks at bad legislation affecting LGBT people and women and bringing that up, trying to raise awareness, trying to bring people to the Capitol to fight it. Black Mamas ATX that helps give Black doulas to first-time mothers and offers them care packages, trainings, educational, and just a community where they can help learn and grow as a first-time mother. And what we do have is the Lilith Fund. It's a charity here in Texas that helps kind of under the table grow funds and help pay the travel costs for people seeking abortions. So those are just some of the groups that we've worked with, but it is an ongoing battle. It is an uphill battle. And with the number of issues that we have, it's hard to focus on anything in particular here in Texas. And I want to say that's most of what I've got.
Yeah, thank you so much for that. That is a lot. There's a lot to fight against and to fight for. I really appreciate that summary. We'll go to our last speaker before we have discussion. Our last, but definitely not least, Kirsten Moore. Kirsten is the director of the Expanding Medication Abortion Access Project, or the EMAA Project. She has almost 40 years of advocacy experience for issues including abortion access and gun violence prevention. Under her leadership, the Reproductive Health Technologies Project was at the forefront of a 10-year effort to bring Plan B emergency contraception over the counter. She had a brief stint with Pew Charitable Trusts, managing a portfolio to advance the public interest in a range of FDA policies, after which Kirsten started the Expanding Medication Abortion Access Project in 2018. EMAA is focused on getting the FDA to change the way it regulates distribution of medication abortion pills in the US, consistent with the evidence and with people's needs. EMAA is now focused on ensuring that people in all 50 states have access to mifepristone. Please welcome Kirsten.
Thanks, Susan. Appreciate that. And I appreciate hearing the hard work that's going on in states. I'm based in Washington, D.C., so I'm not having to fight that, but I am also occupied at the moment. So I'm feeling some of that same maybe stress that I haven't felt before. Anyway, so yes, Emma is focused on ensuring that people in all 50 states continue to have access to mifepristone. And just taking a quick step back, FDA first approved mifepristone in the year 2000. And Miffy is a hormone that Miffy is a medication that shuts down the hormones that are necessary to continue a pregnancy. And so people take that medication and then they take misoprostol. And misoprostol is medication that causes cramping and bleeding. So the fertilized embryo detaches from the uterine wall, and then misoprostol causes cramping and bleeding. So that embryo passes through the body and ends a pregnancy. It has been used in the United States for 25 years. It has an incredibly reassuring safety track record. I'm going to botch the number, but like less than 0.02% of serious adverse events. It's very efficient, very effective. You know, excuse me, Katie was saying, it's not for everybody, but it is an important addition to the mix, especially in these days when states have enacted abortion bans. There are laws on the books that are allowing licensed healthcare providers, well, two things I will say, sorry. FDA had initially required that FDA put restrictions on who can prescribe and dispense mifepristone, some of which have been loosened, but some of which still exist. But the one that was loosened in 2021 and then kind of updated or tweaked in 2023 was getting rid of a requirement that a patient had to come into a clinic and take mifepristone or get mifepristone in that clinic. So you still have to go find a prescriber who's willing to certify to prescribe the medication. But that has enabled getting rid of the in-person distribution requirement, has allowed providers to start using telehealth more broadly. And then a handful of states, about 8, have enacted what are called shield laws. So usually if you're a licensed healthcare provider, you can only prescribe or practice in the state in which you've been licensed. But these shield laws acknowledge that when it comes to abortion with state bans, if you're licensed in, say, New York or Massachusetts, you can, if a patient comes to you virtually through telehealth from Texas, consult with that patient, help them decide, is mifepristone the right thing for them? And if yes, you ask a few basic questions. That's very simple, very straightforward. When was your last menstrual period? Because you want to know, again, that they're 10 or in some cases 11 weeks pregnant. You ask about medical history to determine that there hasn't been an ectopic pregnancy or something to be worried along those lines. And you ask about the need for backup care, where you might go for backup care if you need that. So, and okay, I'm about to lose power. Hopefully I won't. Anyway, so now the shield laws, again, allow providers, licensed healthcare providers in a state like Massachusetts to consult with patients in Texas, and then they can send the prescription through a mail order pharmacy that will deliver to people in Texas, or they themselves can ship directly to that person in Texas. So again, as Katie said, today, nationally speaking, medication abortion counts for 64% of all abortions, and these telehealth visits count for about 24% of all abortions. So this has been a game changer, and obviously it's pissing the opposition off. You know, they repealed Roe. They thought they would have a dramatic downturn in the numbers of abortion, and it turns out that with telehealth and MIFI, where the numbers of abortions are remaining the same because people's sexual habits haven't really changed, and people's desires to have children or not be able to have children or not be able to take care, not feel confident that it can take care of all the children is still real, because Republicans, as Toga was just telling us, haven't done anything to fix and you know, they haven't done anything to fix people's real world experiences. So those decisions are still getting made. The Trump administration we're watching with very bated breath to see what they might do to try to limit access to mifepristone. There's been some chatter, you might have heard about it, about, you know, they're going to come at us, as I say, through legislation, litigation, or regulation. So on the legislation, there's stuff that there are like 20 bills that have been introduced. Oh, healthcare providers can't provide mifepristone. Oh, mifepristone can't be mailed. They'll invoke the Comstock law from 1873, that says that abortion, contraception, and other materials can't be sent through the mail. They've got state laws, right? Louisiana last year enacted a law that said, well, because of this potential risk or misuse or misdirection, somebody getting abortion pills that they didn't know they were getting, we're going to schedule mifepristone and misoprostol, meaning those pills will now be kept literally under lock and key, even though misoprostol is a drug used throughout pregnancy to help people deliver a healthy baby, among other things. That law in Louisiana attracted a lot of media attention last year, and other states introduced similar legislation this year, but nobody has since passed it. So I think they've realized, like, that may be a bridge too far. We'll see. So that's legislation. Litigation, they're coming at us again through a number of different fronts, but most notably, the attorneys general from Kansas, Missouri, and Idaho have filed a lawsuit in front of Judge Kaczmarek in Amarillo, Texas, cherry-picked for this whole effort, put on the bench by Leonard Leo for this whole effort. And in that litigation, they argue that FDA removed the in-person distribution requirement in a pre-Dobbs world. And now we're in a post-Dobbs world, and voters in and people in their states are still getting abortions because of this telehealth visit. Now, keep in mind, the Kansas and Missouri voters have spoken loudly and clearly and said, we think women in our state should have the right to make their own decisions about their own bodies. Idaho, potentially different story. But that case is sitting in front of Judge Kaczmarek right now. Worth noting that this Department of Justice, Trump's Department of Justice, filed a brief in that case and says those 3 attorneys general don't have standing in Texas, should not be able to move forward with that case. They didn't do it, obviously, based on mifepristone. They did it because they don't want blue states to be emboldened to challenge federal laws, regulations, et cetera. But so that litigation is pending. And then regulation, right? There could be pressure put on FDA to, again, reinstate the in-person distribution requirement. There's a lot of chatter about this junk science that, again, Leonard Leo has funded through something called the Ethics and Public Policy Center that says, oh, wait a minute, Miffy isn't as safe as the proponents have described. There are multiple adverse events that have gone unreported. Well, those adverse events, for the most part, are not connected with the use of the drug. There's something that happened, with the patient within a 2-week period, or it's patients going into a hospital, an emergency room, to confirm that, in fact, the pregnancy is no longer there. They're just getting an ultrasound, and this is how they can do it. So we're watching all of this with bated breath. For what it's worth, and I want to give people some slim chance hope, I am skeptical that the Trump administration is going to do anything drastic on mifepristone, mostly because, again, this is a method that's used primarily 10 weeks or less in pregnancy. And Trump knows that's a bad look. He is on record as saying, even though he takes credit for appointing the Supreme Court that overturned Roe, he also knows that it was a politically not good look for him. And it's not clear to me that he feels any obligation to the right to life movement on this front. He, again, literally has been quoted as saying, I've done what I have to do for them. I don't owe them anything. But that being said, we are very worried about what might happen next. And so I'm going to try, I think, to share my screen because I would like to show you all. Yeah. Okay. Hopefully did it. Miffy in all 50. And so this is a very simple website, and this is the cover page. So we recognize that most people don't know what Miffy is, haven't heard anything about it, but just seeing this, we did a test online, 1,300, I don't know what you call them, viewers, I guess, viewers. And the majority of the people who are in our base, all they see is that, and they're like, yeah, that's trustworthy, that's believable, I want to share it. So it's very simple information to pass along to others in your network. Say it with us, Miffy belongs in all 50 states. And what we've done is just try to well, I'll come back to the take action. We've just outlined again Congress's junk science junkyard. We're going to put up some new information about the litigation that I mentioned and some of the junk science that's being used, et cetera. But really what we're asking people to do is literally send a note to President Trump to say, don't go here. Don't reinstate the in-person distribution requirement. Don't ignore the science. This is safe and effective, and it's incredibly important. And so we hope that if you have the capacity, that this is something that you will share with your networks, even just, the link to the page, miffyandall50.org. If you're so inclined, sorry, I'm sitting here trying to pull things out of we have some swag, some postcards, Miffy and All 50, and stickers, so you can be in touch with me. I'll put my name and my email address in the chat right after this. And let us know if you're doing any local event that you want to have some stuff to hand out. We'd be happy to partner with you. I should be really clear, Emma is a one-person organization, me. I work with a group of consultants because we're very deep in the FDA policy world, but I appreciate the work that people do on the ground, and we'll meet you halfway to try to help spread the word about Miffy and All 50. So with that, I'll pass the mic back to you, Susan.
Thanks so much. That's great. That's also, I like how catchy that is. Makes it really easy to say and remember and spread the message. I love it. All right, so we'll go ahead and stop the recording and open up discussion. A few notes, like please raise your hand. I'll call on folks in the order that I see hands go up. And I also ask that you turn on your cameras where you're able to do so we can see you, and please introduce yourself too, so that we can, when you go to speak, so that we can get to know each other better.